Welcome back to another episode of HealthCap Weekly Wrap.
Today, we've got a wide range of stories to dig into. Infection control, federal fraud enforcement, tricky ethical territory with admissions, clinical updates on flu season, prescribing risks, and even the pros and cons of second opinions. Whether you're on the clinical side, in administration, or supporting staff on the ground, there's something in here for everyone working in post-acute care. So let's jump right in.
All right, let's start with that new study from PubMed on enhanced barrier precautions in chronic ventilator units. Did you get a chance to read that one?
Yeah, I did. And I think it's one of those studies that could quietly have a big impact if the findings catch on. So they looked at 2 ventilator units in post-acute communities, and they tested how well enhanced barrier precautions worked to reduce the spread of multi-drug resistant organisms.
And by enhanced, they mean staff wearing gowns and gloves, not just for isolated residents, but anytime they're providing high-contact care to residents who are colonized but not actively infected, right?
Exactly. Things like helping with hygiene, dressing changes, repositioning, all the stuff that happens constantly in ventilator care.
And the results were pretty compelling. One site saw a 67% drop in transmission, the other about 25%.
Yeah, even though not all of it hits statistical significance, it's still clinically meaningful. These are organisms like Staph aureus and carbapenem-resistant strains, the kind that are incredibly hard to treat once they take hold.
And the takeaway here is that these precautions don't require isolation. That's huge in post-acute care, where isolating residents can be emotionally and physically detrimental.
Absolutely. We're always trying to strike that balance, preventing infections without making residents feel like they're cut off from the world.
So if you're running or working in a post-acute community with ventilator support, this is a good time to reassess your protocols. Are you using barrier precautions consistently? Do staff understand when and why to use them?
And also, is your team trained on how to use them without disrupting the resident experience? Because we know compliance drops when PPE feels burdensome or confusing.
Totally. This study opens the door for practical, scalable infection prevention in higher acuity environments. And it gives us some real numbers to work with.
Okay, shifting gears. Let's talk about that DOJ news out of Chicago.
Right. So the U.S. Attorney's Office there has launched a dedicated healthcare fraud section. 6 prosecutors focused on financial crimes like false claims, fraudulent billing, kickbacks, and schemes targeting Medicare and Medicaid.
And while it's not directly aimed at post-acute care communities, the implications are pretty clear. We're a Medicare-heavy sector. This kind of enforcement focus is going to hit close to home.
Yeah, and it's not just big hospital systems getting attention anymore. Smaller providers, including those in post-acute, are increasingly on the radar if there's evidence of systemic billing issues.
Especially if those billing practices suggest overbilling, ghost services, or anything that leads to residents not getting the care they're being charged for.
That's what makes it relevant. Fraudulent billing doesn't just hurt the government's wallet. It often reflects deeper operational problems.
So what should post-acute leaders be doing right now? I'd say audit your billing processes, double-check your documentation, make sure your staff understand what qualifies as billable care,
And have someone outside the usual billing team review it. Sometimes a fresh set of eyes catches patterns that feel normal internally but look questionable from the outside.
Exactly. The goal is to provide great care and bill honestly for what you provide. That protects your residents and your community.
Now let's talk about a really difficult but important issue. The McKnight's article on long-term care for aging individuals who are on sex offender registries.
Yeah, this one is tough. And it's something that's only going to become more common as that population ages.
Right. The article dives into how post-acute communities are struggling to handle admissions for these individuals, especially when there are state laws that require public notification or when families push back.
And a lot of providers are defaulting to blanket denials, mostly out of fear of liability or concerns about community reactions.
But that creates a serious problem. These individuals still have medical needs. They need rehab, skilled nursing, even memory care in some cases. If every community says no, where do they go?
Exactly. And the experts in the article frame it as both a public health challenge and a social justice issue. Everyone has the right to medical care, even people with a criminal history.
The article suggests individualized risk assessments instead of one-size-fits-all policies. That makes sense. Someone who committed a crime decades ago and hasn't reoffended may pose little risk.
And it brings up something we don't talk about enough: how we protect all residents while still honoring individual rights and needs.
This isn't an easy fix. It's going to require new policies, staff training, and support from regulators. But it's coming, and we need to be ready.
Absolutely. If your community doesn't already have a plan for how to evaluate these situations, now's the time to start that conversation.
Okay, moving on to clinical guidance. The CDC just released its recommendations for the 2025 to 2026 flu season. Did anything stand out to you?
A few things. First, they're again prioritizing high-dose or adjuvanted flu vaccines for adults 65 and older, which includes pretty much our entire resident population.
Yeah, and they emphasized early treatment with antivirals for anyone at high risk, even if symptoms seem mild. That's important because flu in older adults can present so differently.
Totally. It might look like confusion, a fall, or even just fatigue, not the classic fever and cough. And missing those early signs can lead to bigger problems fast.
They also doubled down on staff vaccination. CDC actually said staff immunization is foundational for outbreak prevention in post-acute settings.
And it is. We've seen how one unvaccinated staff member can start a chain reaction. Flu spreads fast in close quarters.
So now is the time to plan. Order vaccines, schedule clinics, educate staff, and maybe think about offering incentives to boost uptake.
And don't forget about COVID, it's still out there. Communities should plan for co-circulation and be ready to respond to both.
All right, let's talk prescribing. There was a really eye-opening study in JAGS about what they're calling a diuretic prescribing cascade.
Yeah, it starts with a resident being prescribed a calcium channel blocker for hypertension. Those meds can cause peripheral edema. So then a provider adds a diuretic to manage the swelling.
Which sounds reasonable until you realize you might be treating a side effect as if it's a new condition.
Exactly. And then the diuretic causes dehydration, or low sodium, or even contributes to falls, all from a chain reaction that might not have been necessary.
This is a classic prescribing cascade, and it's especially dangerous in post-acute care where residents are already vulnerable.
It really highlights the need for regular, thoughtful med reviews, not just at admission, but anytime a new symptom pops up.
And not just by the physician. Nurses, pharmacists, aides, everyone should feel empowered to say, hey, this started after we added that medication. Could it be connected?
It's about building a culture where we treat prescribing like detective work, not just a checklist.
And sometimes the best intervention isn't adding another med, it's stepping back and asking, why is this happening?
Okay, let's wrap up with something that might seem small, but actually could be one of the biggest moments in the care experience. It's an opinion piece from MedPage Today about something the author calls the goodbye.
Yeah, and she argues that the last 5 minutes of an encounter, especially during discharge, can make or break the entire experience for the patient or resident.
Exactly. You could deliver excellent clinical care, manage pain, follow protocols, but if the discharge is chaotic, unclear, or cold, that's what the person remembers. And in today's healthcare world, that memory affects more than just satisfaction scores. It impacts loyalty, referrals, and even reimbursement. CMS ties up to 25% of value-based purchasing to satisfaction metrics now.
She outlines 4 things providers can do to make the goodbye count. First, it should come from a clinician, not just someone at the front desk.
Second, it needs to be both clinical and personal. That means clearly explaining the next steps, checking for understanding, and offering a bit of reassurance.
Third, put it in writing. A personalized summary, not just a generic discharge packet, can really help residents retain and follow through on instructions.
And finally, say thank you. It sounds simple, but it can be powerful. Thanking someone for trusting you with their care builds a lasting connection.
This really applies to post-acute care. Think about discharges from rehab, transitions to home, even daily handoffs between shifts. that closing moment sticks.
Exactly. And it's one of the few things we actually can control. A strong, clear goodbye builds trust. A rushed or confusing one can undo days of great work.
So whether you're a nurse, a provider, or part of the support staff, it's worth asking yourself, how are we ending each interaction? Are we leaving people with confidence and clarity?
And on that note, it feels fitting to bring our own conversation to a close.
Thanks so much for listening. You can find more details about these stories, plus additional insights and updates in the weekly roundup on Angie's blog at healthcapusa.com/Angie's blog.
Take care, and we'll catch you next time.